Hi, this is Nick Fletcher at the Children's Healthcare of Atlanta, where I serve as the Medical Director of Quality and Outcomes for our spine program. I'm going to be talking to you today about our research focusing on perioperative administration of dexamethasone in patients undergoing posterior spinal fusion for adolescent idiopathic scoliosis. I'd like to thank our team for their hard work on this, especially Tracy Ruska, our excellent nurse practitioner. This study is really the culmination of several years of work that our team has put together trying to minimize postoperative pain and improve postoperative efficiency following spinal fusion for idiopathic scoliosis. The addition of steroids was really the cherry on top, if you will, and the concept for this came out of a discussion a few years ago with our adult arthroplasty colleagues who had added postoperative dexamethasone to their outpatient total joint arthroplasty protocols. In their eyes, they had not seen any increase in wound complications. And in doing a relatively thorough literature review, we also found that there is no literature that suggests that the addition of postoperative dexamethasone would increase wound infection in the obstetrics literature, vascular literature, general surgery literature, or even other orthopedic fields. So with this in mind, we decided to implement 3 postoperative doses of dexamethasone in addition to the typical intraoperative dose that the patients had been receiving. The average dose was 8 milligrams, and to be honest, this wasn't calculated in a very scientific manner, but was simply done based on the anesthesiologist's recommendations. Our data suggested that the total morphine equivalent dosage decreased by 40% after the addition of our dexamethasone, and when accounting for weight, we saw about a 30% decrease in weight-based morphine equivalent usage. In addition to this, we found that patients on average walked nearly twice as early with physical therapy on postoperative day 1, and that length of stay dropped from just over 2 days to 1.92 days after addition of dexamethasone. As we expected, based on our discussions with our colleagues, there really was no increased risk in wound complications or wound infection. There were no infections in the steroid group and only 1 infection in the non-steroid group, and no difference in wound complications altogether. So I think that this study has a lot of benefit that can offer for surgeons and patients. Certainly the addition of something as readily available as dexamethasone that is well tolerated makes it so that this can be used really nationally and internationally in most settings to decrease postoperative pain. Certainly the risk profile is well known in this medication class, and it overall seems to be quite safe and certainly doesn't involve any other addictive substances. There are a few limitations to the study, and certainly the fact that we only followed our patients for 3 months, which was based on the CDC's recommendations regarding classification of postoperative infection, limits our ability to comment on things like pseudarthrosis, although I'll tell you now that this data is a couple of years out. We have not revised anybody to date for pseudarthrosis, but certainly more work needs to be done there. So I would strongly consider, if you are a pediatric spine surgeon, the addition of perioperative steroids to your patients undergoing spinal fusion for idiopathic scoliosis. And we are also extrapolating this data and using this in our neuromuscular patients who are undergoing spine fusion or hip reconstructions, as well as other large orthopedic surgeries. So I really appreciate the time today, and thank you for listening to my video. Please be well. Thank you.